Welcome to today's Explainer. We are jumping straight into the trauma bay to decode exactly what goes on during those critical first few minutes when a patient arrives with a potential spinal injury. We're going to explore the intense, step-by-step biomechanics and the life-saving protocols of acute spinal trauma management. We are getting right down to the core science, the anatomy, and the razor-thin, split-second decisions that can literally mean the difference between a patient walking again or facing permanent paralysis.
Here is our roadmap for today. We're covering the golden rule of triage, the rules of spinal imaging, the mechanics of vertebral fractures, mapping incomplete cord syndromes, and finally, surviving neurogenic shock.
All right, Section 1, the golden rule of triage. Let's dive right into those immediate priorities. To really understand this, picture this clinical scenario. Imagine a 14-year-old drowning victim is brought into the bay. They're awake, but they're complaining that it's hard to turn their head, and they've got this tingling sensation in their fingers. So what is your absolute first step? Well, what's really fascinating here is that the drowning, it's kind of a distraction. Those peripheral neurological symptoms, the finger tingling and the restricted neck movement, those are massive red flags. They completely dictate everything that happens next.
Those specific symptoms mean you must immediately assume a cervical spine injury. No questions asked. Your absolute mandate is to immobilize first. You've got to apply a rigid cervical collar and sandbags to stop any micromotion that could actually transect the spinal cord. And why is this so absolutely crucial? Because up to 10% of patients with moderate to severe traumatic brain injuries actually have a coexisting cervical spine injury. And hey, if you need to secure their airway, like if you need to perform endotracheal intubation, you definitely don't just tilt their head back. You carefully unbuckle the front of that collar, and a dedicated team member provides strict manual inline axial stabilization to keep that spine perfectly neutral the entire time.
Moving on to Section 2, rules of spinal imaging.
Now this brings us to an absolute, unbreakable rule of acute trauma. Dynamic flexion and extension radiographs are absolutely contraindicated in the acute setting. Why? Because forcing an unstable spine through a range of motion can physically induce primary cord compression, or even worse, completely transect the spinal cord right there. Instead, we rely on a standard acute clearance panel. That means an anteroposterior view, an open-mouth odontoid view, and a cross-table lateral view, which, by the way, is incredibly sensitive for checking the alignment at the easily missed C7-T1 junction.
Okay, Section 3, mechanics of vertebral fractures. Let's talk structural integrity. Whiplash is a really fascinating example of an acceleration-deceleration injury, which you typically see from a car crash. The head is whipped backward into rapid hyperextension and then violently thrown forward into rebound hyperflexion. The really crucial takeaway here is that whiplash is purely a soft tissue strain injury. If you take a plain radiograph, you're going to see zero structural bone fractures. Yet, the symptoms, like severe neck stiffness and muscle spasms, well, those can be severely delayed, sometimes not showing up until days later.
But what happens when the kinetic energy is much, much higher? Think about a high-speed crash where the patient wasn't wearing a seatbelt. If a patient comes in with a structural sternal bruise, so a fractured breastbone, and that's paired with posterior rib or thoracic spine fractures, you need to pay incredibly close attention. This combination means a massive kinetic deceleration force passed straight through their chest, right through the mediastinum. And that specific pattern, it carries a shockingly high risk of traumatic rupture of the thoracic aorta. If you don't screen for this hidden mediastinal injury right away, the patient could rapidly exsanguinate.
Now, looking at the spine itself, where is it most vulnerable to breaking? The answer is the T12-L1 transition zone. Roughly 60% of all post-traumatic vertebral column fractures happen right at this specific thoracolumbar junction. Why there? Because it's a sudden biomechanical shift. The rigid, non-compliant thoracic spine, which is nicely stabilized by your ribcage, abruptly ends and it meets the highly mobile, flexible lumbar spine. This sudden transition makes the T12-L1 zone a focal point for massive stress concentration during any kind of traumatic loading.
And how these fractures behave really depends entirely on where they happen. Let's compare cervical burst fractures with lumbar burst fractures. A cervical burst fracture, like the classic Jefferson fracture of the C1 ring, often pushes retropulsed bone fragments directly into the spinal canal. That causes severe neurological deficits. But if you have a lumbar burst fracture, let's say at L2, where the patient is totally neurologically intact with absolutely no deficits, the whole goal changes. You don't actually need a surgical decompression or laminectomy. You simply need transpedicle posterior stabilization just to secure those biomechanically unstable vertebral columns.
Section 4. Mapping incomplete cord syndromes. Let's look at the neurological fallout.
First off, how do we even grade the severity of these injuries? Clinicians use the Frankel classification scale to categorize severity based on whatever function is preserved below the level of the injury. So, for instance, if a patient gets hit by a car and comes in with their sensation intact, but they have absolutely zero motor activity, total paralysis, they're classified as a Frankel grade B. It's an incomplete injury with sensory preservation only.
Now let's map out a really specific, unique injury called Brown-Séquard syndrome. Imagine a lateral hemisection of the spinal cord, maybe from a stab wound. The resulting symptoms perfectly trace the anatomical pathways, like a map. Because the dorsal columns and motor corticospinal tracts don't cross over at that spinal level, damage causes a loss of movement, vibration, and proprioception on the exact same side, the ipsilateral side of the injury. But the lateral spinothalamic tract, which carries pain and temperature, crosses over almost immediately. So damage there causes a loss of pain and temperature appreciation on the opposite or contralateral side of the body. It's wild, right?
Then we have central cord syndrome, which is actually the most common incomplete injury pattern we see. This usually happens in older patients who already have some spinal stenosis, and then they suffer a hyperextension injury to the neck. This triggers ischemia and swelling right in the central microvascular watershed zone of the cord. And the topographic mapping here is just incredible. The nerve fibers for your upper body live medially, right in the middle of the cord, while the fibers for your lower body live on the outside, laterally. Since the swelling starts dead center, it brilliantly illustrates exactly why a central neck injury makes a patient's arms so much weaker than their legs.
Because of this specific inside-out anatomy, the timeline of motor recovery in central cord syndrome is actually highly predictable. As that central swelling subsides, function slowly returns from the outside of the cord inward, so the lower extremities recover first, followed by bladder function, then the proximal upper extremities, and finally, the absolute last things to recover are the intrinsic muscles of the fingers, because their nerve fibers live in the absolute deepest center of the tract.
But remember, geography in the spine literally dictates survival. A mid-cervical injury at the C3, C4, or C5 level isn't just a matter of quadriplegia. These specific nerve roots form the phrenic nerve, and the phrenic nerve provides the primary motor innervation to your diaphragm, so an injury at C3 to C5 equals immediate diaphragmatic paralysis and respiratory arrest. This presentation demands immediate mechanical ventilation just to sustain the patient's life.
And finally, Section 5, Surviving Neurogenic Shock. Neurogenic shock kicks in when an injury above the T6 level physically severs the descending sympathetic pathway. You completely lose vasomotor tone and sympathetic input to the heart. There's a fascinating paradox here when you compare it to hypovolemic shock from blood loss. Instead of a fast heart rate and cold, clammy skin, a neurogenic shock patient shows widespread vasodilation causing warm, flushed skin and systemic hypotension. And this is paired with bradycardia, a dangerously slow heart rate because the body has completely lost its ability to mount a compensatory tachycardia.
So, put yourself in this high-stakes scenario. The patient is profoundly hypotensive and bradycardic. You've already completed the initial fluid resuscitation to fill up that expanded vascular space, but their blood pressure is still crashing. What is the very first-line vasoactive drug you've got to administer?
The answer? It's dopamine. This is a brilliant example of how we have to counteract very specific autonomic failures. Because bradycardia is a major compounding factor here, a pure vasoconstrictor just isn't going to fix the whole problem. Dopamine is perfect because of its dual action. It provides vital alpha-1 adrenergic vasoconstriction to squeeze those blood vessels and restore vascular tone, while simultaneously providing beta-1 chronotropic and inotropic support to kickstart that dangerously slow heart rate.
And that brings us right back to our starting point, leaving us with this absolute, non-negotiable clinical rule. Every high-energy trauma patient must be managed under the absolute assumption of a cervical spine injury until formally cleared. From the precise mechanics of a T12 burst fracture to the terrifying cardiovascular collapse of neurogenic shock, it is truly incredible how these intricate biological mechanics dictate the razor-thin line between paralysis and recovery. It really leaves you wondering, as emergency medicine continues to evolve, what new technologies will eventually allow us to reverse these catastrophic injuries entirely? Until then, I'll see you in the next explainer.